was trying to do, which is provide his own rendition of Mona Lisa. So let's go to neonatal encephalopathy. And the reason I chose the Mona Lisa before this is because it is likely that every radiologist that encounters neonatal encephalopathy and neonatal scans has seen a version of adult brain injuries, because they're overwhelmingly more common when we are training. The neonatal encephalopathy and perinatal brain injuries are a version of this. There certainly are some semblances of adult brain injuries, but they're also independent and quite unique. In terms of their incidence, give or take 9 per 100,000 live births, we're going to be discussing and talking mostly about term newborns. There are a number of peculiar and unique features when you're dealing with preterm birth that we won't be focusing on here. And this is how they present. And I want to emphasize this: the neonatal encephalopathy is the preferred term as opposed to perinatal asphyxia and many others, because it is a clinical syndrome and it is defined clinically, and it can be multifactorial. So it is true, and I'm getting ahead of myself, that hypoxia and ischemia are probably the most common cause of neonatal encephalopathy, but they're not the only one. And we should avoid that bias of putting ourselves into a category that we can't get out of, and for that reason make a mistake. The characteristics of neonatal encephalopathy include seizures, which are common but not required for the diagnosis of neonatal encephalopathy. Abnormal tone and reflexes. The tone can go in both directions. They can be hypertonic or they can be hypotonic if things are severe. The consciousness of the newborn is important, and the ability to initiate and maintain healthy respiration. So this is actually a very fine clinical diagnosis that has to be approached. And what I wanted to sort of emphasize one more time is there's tons going on here. And the diagnosis has to be reached mostly with clinical input in a very short amount of time to be able to triage this patient appropriately to certain interventions. But I wanted to sort of emphasize and not diminish the fact that EEG, for example, provides you tremendous information. It may not be available in those first hours of life, but you can see it up top. This is a baby that had mild encephalopathy, but still has a normal EEG, which is what you'd expect for someone in the mild category. The one in the bottom is someone who has moderate encephalopathy and has an abnormal background with areas of burst and then areas of suppression. So this is a very concerning EEG. And I'm going to try to invite you through the talk to try to bring the pieces together, because we are looking at the MRI, but certainly a lot more is going on in those patients. So this slide is also important. I put hypoxic ischemic injury at the top left. That's where we all start. And overwhelmingly, that is the most common cause of encephalopathy. That's also not the only one. So I think it behooves us to take a look at this large landscape and realize that any given one of these could be doing that. And when things don't seem to be going in the direction, or the pieces seem to not fit together nicely, we should be thinking outside of the box and double checking that there is none of these other possible confounding factors, or that there isn't a combination of them playing into the presentation of this patient. So getting back to hypoxic ischemic injury as the main cause, I'm a very simple-minded person. People will, write whole textbooks, and that's great. They have a tremendous understanding of it. But the way I sort of think about it is, being born is a fairly stressful period. It's a fairly stressful process. There are changes in hemodynamics. There's compression of the head. There are changes in heart rate. And you may become hypoxic for periods of time, be that because there is a decrease in oxygen, or there's a decrease in the overall perfusion you're getting related to a number of things. Some of them are related to the baby. You could have congenital heart disease. You could have a congenital diaphragmatic hernia. Some may be maternal. Maybe mom has congenital heart disease. Some of them may be related to the pregnancy. There's underlying IUGR. But there are two factors that sort of become multiplicative, if you will. And one of them is the severity, and another one is the duration of the period of hypoxia and ischemia that will conjure the severity of the injury. So if you have really severe hypoxia and ischemia, and it takes a long time for you to get out through the birth canal, so you're exposed to this for a long period of time, that's not a difficult decision to make, and the outcome will be very clear. You're going to have a very diffuse pattern of injury, and the reason for that is simply, eventually, if you cut off blood supply to neurons long enough, every single neuron will die. Obviously, moving towards the right, if you have a period of hypoxia that's very severe, but it didn't last for that long, then the tissues that are going to be hit are those tissues that have the highest metabolic demand. So you're going to end up with an injury of vulnerability because your body, the mom's body or the baby's body, was able to bring up perfusion, but it took him some time. The third one is if you're not presented with a severe and short injury, but much rather a longer injury or longer insult that isn't as severe, you may be able to compensate, at least for some time. But then what's going to happen is eventually your compensatory mechanisms are going to become fatigued. And when they become fatigued, you're going to start to experience injuries in other places because you have had a warning, or the baby's body's had a warning. So it will try to protect certain areas and it will prioritize those areas. And then, as it happens every time we're multitasking, something's going to fall through the cracks. And then the last of all of them is if the injury is not severe enough, or if it's brief, the baby may actually come out triumphant, and then he or she may be spared from injury under those circumstances. So another important part that I want to bring to the top here, there are many prettier diagrams of this. Once again, this is sort of my binning of what I think is going on in hypoxic ischemic injury. Let's step away from the obvious adult stroke, which is sort of a all or nothing insult, where you block a large vessel. And once you block the large vessel, well, there's only one thing that's going to happen to the neurons that are supplied by the perfusion from that vessel, and they're all going to die. So there will be like red neurons here. However, perinatal asphyxia, infant asphyxia, or any sort of perinatal brain injury or sentinel event, it's not as black or white, meaning you didn't really cut off any single vessel. You sort of globally decrease perfusion. So you're going to end up with a combination of these colors. The red are neurons that actually die there on the spot. So if you're either a neuron that's very active and highly vulnerable, or the injury is severe enough, you're just going to die. There's really nothing to do. And you're going to change to restricting diffusion very promptly within hours. Now, there are neurons that aren't killed on the spot, but that are irreparably injured. So those may not die immediately, but you'll basically see them succumb to their injuries in the next couple of days. So there's an evolution to this injury. And the last thing I'd say is even though some of the neurons may not be, let's say, lethally injured by the hypoxia and ischemia, it is quite possible that we'll end up with some that trigger apoptosis and programmed cell death by the injury. So there's these three categories of cells that some are going to die immediately and some are destined to die after this injury. And of course, there's the fourth one that we hope there's a ton of, and there are neurons that may be spared. So in any single instance of hypoxia ischemia, you will probably have a category of all of these existing. We would hope to have more blue and green ones than red ones, but ultimately there probably are some neurons in all of these categories. The last thing I'll emphasize here is the orange and yellow categories, to emphasize that this is an evolving injury. So these two categories are really the justification to think about doing something. We are unable to save the neurons that are already dead, and we don't need to save the ones that aren't actually much injured. But we need to do something to address that orange and yellow categories. And when we do those things, it's therapeutic hypothermia. I'm not going to dive too deep in this, but I think we all have been exposed to this. Colloquially speaking, we cool the baby 3 degrees for 3 days. And it's considered to be standard of care for moderate and severe neonatal encephalopathy. And it definitely decreases the rate of death and major disability in these two. In mild encephalopathy, the jury is still out as to what are the gains from this. But many centers, given how benign the safety profile of therapeutic hypothermia is, they may still cool newborns with mild encephalopathy. The second bullet point here tells you what it does. When we cool the baby, it decreases the metabolic rate, it decreases the oxygen demand of tissues, it decreases the inflammation, and it inhibits the molecular onset of apoptosis. So we're trying to really address those orange and yellow categories that I showed you in the slides before. And the last thing to note about this is that we are actually not involved in the decision to cool a baby. We generally obtain the MRI after the hypothermia protocol is complete. So day of life 4, or 5. And here's a little bit about the timeline and the evolution of that. Generally, in the first 3 days of life, the baby is under the hypothermia protocol, so we don't actually image them here, not under normal circumstances. We tend to image them here. And that's actually a reasonable time to image because we think that most, or at least some of the diffusion is going to be apparent by day 3 to 5. It is also known that the hypothermia may delay the development of some of these imaging findings. I don't know of any specific reference that actually tells you the chronologic evolution of these injuries when hypothermia has been applied. There's some terrific work from the 1990s from UCSF that timed it better in newborns that were not cooled. But after cooling, we expect cooling to have an effect, the effect being delaying and hopefully mitigating some of that. But we don't actually have an itemized version of that. So we generally cool here, we image here after cooling. And with that, we use the information to get a survey of what the landscape is of brain injury at the time of the MRI. But as I mentioned, the injury is going to continue to evolve. So let's talk a little bit about that HIE central pattern. This is the one that we call vulnerability injury, and it's the one where frequently there is a severe event, but it is short-lived. So the injuries are concentrated and clustered in those areas that have higher metabolic demands. Those in general tend to coincide with areas that are myelinated because we myelinated them for a reason, and is that we needed them to be active. The T1 and the T2 may show changes, but they are actually subtle. So you need a lot of experience and good image quality. You may see some areas that appear T2 bright, and the dark borders of some areas that you would expect in the deep gray nuclei to be hypointense, would start to become fuzzy. Diffusion is, in my opinion, the best way to spot them. You'll see restricted diffusion all through the deep gray nuclei, particularly the ventrolateral thalamus, but it can be in other places. However, these ventrolateral thalamus and the deep gray nuclei are the quintessential feature of a central pattern of hypoxic ischemic injury. As I mentioned, if you keep the hypoxia and ischemia on for longer, you will see these injuries be restricted not so much to these vulnerable territories, but spread out. So they won't be confined to these areas. They'll start to go to other places. We use spectroscopy. I think spectroscopy is a nice adjunct, and for the most part, it goes along with the information that I see on the diffusion and in other sequences. However, you don't necessarily know what you're going to find before you image the baby. So we have it as a fixture of our protocol. You're seeing 2 echo times. The first one is a short echo time with 35 milliseconds. The second one is an intermediate echo time with 130. We do 2 for 2 reasons. One is, even though you see something that looks like a lactate peak at 1.3 ppms, the lipids may also resonate in that location in the short echo time. So we do an intermediate echo time at 135, but you could also choose to do a long echo time of 270. In the intermediate echo time, you're going to see an inversion of the doublet. In the long echo time, you're going to see an upward pointing doublet, but the lipids would have faded away. So in the long echo time, any semblance of a peak at 1.3 ppm that you retain is going to be lactate. The reason to keep the short echo time is that it's obviously a richer spectrum with regards to substances and like small molecules that may have shorter T2 values, and for those reasons decay faster. So if you don't know if you may be dealing with some inborn error of metabolism, it is actually helpful to have the full spectrum so that you can work with both. But if you knew you were in the space of hypoxischemia for certain, then I think it actually could be reasonable to just get the intermediate or the long echo time. I wanted to show you this. This is the evolution. This is a baby image at day of life 3 and then a day of life 5. And you can see that the areas of restricted diffusion may become larger. And that's a function of that dynamic nature of the injury that we saw. And that's exactly what we're trying to not entirely curtail, but at least mitigate when we do hypothermia protocol. This is a baby at 1 month of age. At this point, most of the injury has already quieted down. Necrosis has established, tissue loss has been established, and you see areas of T1 shortening and T2 hypointense signal corresponding to the areas of profound injury from that central pattern. The peripheral pattern, as we alluded to, is typically allocated to partial and prolonged hypoxia and ischemia. So I tend to think about this not as failed compensation, but perhaps insufficient compensation. If the baby has a warning the baby will try to protect the deep gray nuclei because he or she knows that those are vulnerable. But if you keep the stress for long enough, some things are going to fall through the cracks. Quintessential and very well-respected studies have shown that there really isn't a pure watershed boundary in the neonatal brain. So some people dislike the term watershed territories when discussing about them. I still find that there's some value to them, at least on the visual approach to them. I think you'll see that some of the injuries tend to cluster in some areas that would be comparable to watershed territories, even if they aren't directly related to that. This type of injury has a better prognosis than the central pattern. And another thing I must say is, as hypoxia, as hypothermia for perinatal hypoxia has become more widespread, we actually see less of this pattern of injury. I think the deployment of therapeutic hypothermia in the clinical realm actually has shifted a bit the type of injuries we see. I would say we see more normal scans. So don't be alarmed if you have someone that comes in with encephalopathy was cool, then you see a normal exam. We are seeing more of those, approximately 50%. I would say the peripheral pattern has really decreased substantially. And we still definitely see some central pattern, but we see less percentile-wise compared to before. I also wanted to show you this diffuse pattern. You hope you never encounter one of these things, but it stands to reason that if the hypoxia is severe enough, it's no longer about vulnerability or your ability to compensate. Everything will be wiped out. So this is a case of a home delivery where there was a uterine rupture. And you can see everything is gone in the T2s. You see diffuse T2 prolongation. You see diffusion restriction everywhere. You see a lactate peak. And actually, in some cases, if you do ASL, you will see elevated perfusion because the neurons that are alive, they're injured, they're experiencing excitotoxicity, so they're very active. And as you know, neuronal activity is one of the largest drivers of CVF, that basically being the principle on which fMRI was built. So you can see a really elevated CVF as part of those injuries, although I would argue you don't actually need this ASL to make the diagnosis of this injury. Once again, I want to show you the evolution of that pattern of injury. No one expects anything positive to come out of this MRI, but you can see the rapid evolution and this pattern of kind of a devastating, pretty generalized pattern. It's very highly associated with really, really bad outcome, death or really severe neurologic disability, which is intuitive to us. But it is good to know that the positive predictive value of this approaches 100% for a bad outcome. So getting kind of out of the MRI world for a little bit, as I mentioned, I'm not an artist by any means, but I grew up with Juan. My cousin Juan, I call him Jota, which is Jay in Spanish. He's a remarkable artist. And I discovered that at a very early age. So I delegated all of my artsy work on him since I was like 5, and I noticed that he was actually good at what he was doing. So I did very well in art, but more importantly, I like to take credit for his success. So he's mostly a painter by training, but then developed a liking for sculptures. And I'm going to show you also some of his work. To me, that was the first exposure that I really had to art. He always lived very close to me geographically. So I would go to his house, and to me, going to his house was amazing because there's always a bunch of artwork halfway through in different stages of completion. So walking through his house is remarkable. As compared to my apartment, where if you walk to my apartment, all you're going to see is like half full cups of coffee from the day before. So I think we are related, but his skill shows up very promptly. So I wanted to bring in a bit about, he is someone who evolved from being a painter to being a sculptor. And I think we're seeing a very nice trend and evolution of the evaluations of hypoxic ischemic injury. I am showing you some work I did a million years ago, but since then, tons have come up. I would say the best recent work in this space that I know is from UD at UCSF. And the idea is that the diffusion images we get are quantitative, so there's no reason to just stay with the qualitative data. So what we did back then, and he took this to a whole other level, was combine the ADC images into a single virtual subject that's an atlas. And then you can register individual patients to that atlas and compute the Z-scores and see, how far off the mean you are. So these were two newborns that were cooled. There was some equivocating about the newborn on the top to see if he had hypoxic ischemic injury, but you can see that horrendous EEG up top, whereas this one has a normal EEG.